1, 2,
And review 70-year-old female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's charter book.
300 please.
I'll keep your card again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Imagine trying to save the life of a patient who is crashing in the ICU. The alarms are blaring, you need to intervene, but the catch is, well, you can't see them.
Right, you can't even touch them. They're entirely hidden from view inside another patient.
Yeah, which is terrifying. But that is the high-stakes reality of obstetric nursing. You're managing 2 lives simultaneously, balancing competing physiological needs, and, trying to spot a crisis before it even physically materializes.
It is the ultimate test of clinical judgment. And if you're diving into an OB nursing unit or prepping for your exams, you're dealing with a staggering volume of information.
Oh, absolutely. And memorizing textbook tables just won't save that hidden patient. What saves them is pattern recognition.
Exactly. So our goal for this deep dive is to act as your clinical mentors. We're going to aggressively apply the PREO principle to your OB materials today.
Right, so we are hunting for that 20% of high-yield concepts that will give you 80% of the value on the floor and on your exams. We want to build the kind of intuition that keeps mothers and babies safe.
I love that approach. So let's jump straight into the hardest part of this. Monitoring a patient we literally cannot see.
Yeah, if we want to know how the fetus is handling the stress of labor, we rely entirely on fetal heart rate strips. I've always thought of the fetal monitor as essentially a polygraph test for the baby.
That is the perfect framework. Labor is a physiological interrogation.
Right. Because every single time the uterus contracts, it's asking the baby a really stressful question. The contraction squeezes the blood vessels, which temporarily shrinks the oxygen supply.
And the heart rate monitor is our lie detector. It shows us the baby's neurological and cardiovascular response to that shrinking oxygen.
So if the brain is well oxygenated, what does that expected normal baseline look like?
You want to see the heart rate stay between 110 and 160 beats per minute. That's your category I, completely normal baseline.
Okay, 110 to 160. And we also want to see moderate variability, right? Which just looks like those healthy, jagged little fluctuations on the strip.
Yeah, exactly. It means the nervous system is awake and reacting. It's a happy brain. The clinical traps usually appear when that baseline deviates.
Like tachycardia when the baseline goes over 160.
Right. And students often jump to complex fetal conditions there, but the physiological anchor is usually maternal. The baby's environment is heating up.
Oh, so like if the mother has a fever.
Precisely. A fever or an intraamniotic infection like chorioamnionitis, the fetal heart rate just races to compensate.
And on the flip side, severe bradycardia, dropping under 110, tells you the oxygen pipeline is fundamentally obstructed.
Right, perhaps by a compressed umbilical cord.
Yeah.
But the real nuance, the area where exam writers just love to live is the decelerations.
Let's unpack the decelerations, because I'm looking at these strips, and in a panic, an early and a late deceleration can just look like a blurry mess.
They really can.
So mechanistically, what is the anchor to keep them straight in the moment?
You anchor yourself to the peak of the maternal contraction. If you look at an early deceleration, the dip in the fetal heart rate perfectly mirrors the mountain of the contraction.
Okay, so the lowest point of the heart rate matches the absolute tightest squeeze of the uterus.
Yes, it's just a pressure response. The contraction peaks, the baby's head gets squeezed against the birth canal, and the vagus nerve is stimulated.
Which briefly slows the heart.
Exactly. It's a benign expectant vagal response. But a late deceleration happens on delay. The uterus squeezes, the contraction reaches its absolute peak, and
then the fetal heart rate begins to drop.
Right. It's a delayed reaction.
Walk me through the plumbing here. Like, why does the heart rate drop on a delay?
Because of uteroplacental insufficiency. During the peak of a strong contraction, the blood vessels in the placenta are squeezed completely shut.
Okay, but a healthy baby can handle that, right?
Usually, yes. A healthy baby has enough oxygen reserve to coast through that temporary shutoff.
Yeah.
But if the placenta is failing, or the reserves are already tapped out, the baby runs out of oxygen right at the peak of the squeeze.
Oh, wow. So the cardiovascular system panics.
Exactly. And the heart rate dips as a late reaction to that hypoxia. It only recovers after the contraction ends and blood flow resumes.
Which means if we see late decelerations, we are looking at a baby who is suffocating.
Yes.
So the priority nursing actions have to be immediate intrauterine resuscitation. We flip the mother to a lateral position to get the weight of the uterus off the major blood vessels.
You flood her system with oxygen. And crucially, if oxytocin is running to stimulate those contractions, you shut it off immediately.
We have to stop the interrogation because the baby is failing the polygraph.
That's perfectly said. And if you see a combination of absent variability, meaning the heart rate line is practically flat combined with recurrent late decelerations, you have crossed into a category through tracing.
And that is an absolute emergency. The baby's brain is no longer compensating, so you need to prep the operating room for an immediate delivery.
Exactly. So to lock this into our clinical intuition, we tie the visual to the cause. Head compression equals early decelerations. Totally normal.
Right. And cord compression equals variable decelerations. Those look like sharp V's on the strip, and your immediate move is to reposition the mother to unpinch that cord.
Yep. Placental insufficiency equals late decelerations, which means stopping the oxytocin. And a Category 3 strip with absent variability and late decels means we are prepping for surgery.
Okay, so we've established how to read the monitor when the baby is stressed. But what happens when that monitor doesn't just show stress, but signals an absolute immediate mechanical failure?
Yeah, and an actual system crash.
Right, what does that look like in obstetrics?
Well, a system crash is a do not pass go scenario. We're talking about seconds dictating whether a baby survives without permanent neurological damage.
So what are the big ones to watch for?
3 major mechanical failures you have to recognize instantly are a prolapsed umbilical cord, a uterine rupture, and a shoulder dystocia.
Let's start with shoulder dystocia because the presentation is so distinct. I mean, the expected finding during pushing is slow, steady, fetal descent. But the catastrophic warning sign is the turtle sign.
Right, the turtle sign. The baby's head delivers, but then immediately retracts tight against the mother's perineum.
Because the shoulder is physically impacted behind the maternal pubic bone.
Exactly.
Yeah.
And the mechanism of intervention here is highly testable because your first instinct is often the exact wrong thing to do.
Really? Why?
Well, if a baby is stuck, human nature says to push from the top to force them out.
Oh, applying fundal pressure, pushing on the top of the uterus.
Which is an absolute never event for shoulder dystocia. Think of a tube of toothpaste where the cap is superglued shut.
Okay.
If you squeeze forcefully from the bottom of the tube, the cap won't pop up. The tube itself will burst.
Oh, wow. So if you apply fundal pressure when the shoulder is stuck against bone, you will literally wedge the shoulder in tighter.
And potentially rupture the mother's uterus in the process.
Okay, so mechanistically, how do we free the shoulder without fundal pressure?
We change the geometry of the pelvis. The nurse initiates the McRoberts maneuver by sharply hyperflexing the mother's legs back toward her abdomen.
Anatomically, that flattens out the maternal sacrum, right?
Yes, and it actually rotates the pubic bone upward, opening the pelvic outlet just enough. You combine that with firm downward pressure directly over the pubic bone suprapubic pressure to physically collapse the baby's shoulder inward and slip it under the bone.
That makes perfect sense. McRoberts and suprapubic pressure. Now, what about a prolapsed umbilical cord? This is where the cord drops down through the cervix ahead of the baby's head.
The clumbing failure here is straightforward but lethal. As the baby's heavy head descends, it crushes the umbilical cord against the mother's pelvis.
Cutting off the oxygen supply entirely?
Right. So if you are doing a vaginal exam and you feel a pulsating cord, your sterile gloved hand stays inside the patient. You manually lift the baby's head up and off that cord, and you do not remove your hand.
You essentially become the physical bridge keeping that baby alive while the bed is literally rolled into the operating room.
You are the baby's lifeline.
Man, that is intense. Okay, the third major crash is a uterine rupture. I imagine the clinical signs here are incredibly violent.
They are. You will see a sudden acute loss of fetal station, meaning the baby was descending, and suddenly they slip backward up into the abdomen because the uterine wall has given way.
And the mother will report a sharp tearing pain, right?
Yes, and the monitor will show a total cessation of contractions, quickly followed by profound fetal bradycardia.
Because the structural integrity is just gone, and the single greatest risk factor for the uterus tearing open like that is a scar from a previous C-section.
Exactly. So distilling the chaos of these mechanical emergencies down, Turtle sign means shoulder dystocia, requiring the McRoberts maneuver and suprapubic pressure, never fundal pressure.
Got it. A prolapsed cord requires your hand to elevate the presenting part constantly until delivery.
And sudden tearing pain with a loss of fetal station is a uterine rupture, heavily tied to previous C-section scars.
So those are the mechanical failures, but obstetric emergencies aren't always sudden structural collapses, right?
No, sometimes they're a slow-burning physiological time bomb, which leads us to the premature cascade. Preterm labor, premature rupture of membranes, and infection.
Wait, I need to work through a clinical dilemma here. I'm thinking about premature pre-labor rupture of membranes or PT-PROM.
Okay, let's talk to it.
If a client's water breaks at 32 months, my instinct is that the protective seal around the baby is gone. The sterile environment is compromised. Why wouldn't we just induce labor and deliver the baby immediately to avoid a massive infection?
That tension right there is the core of obstetric clinical judgment. You are constantly weighing two life-threatening risks against each other.
Infection versus prematurity.
Exactly. If you deliver immediately at 32 weeks, you avoid infection, but you subject the neonate to severe complications of prematurity.
Like their lungs haven't produced enough surfactant yet, so the alveoli collapse, leading to massive respiratory distress.
Yes. So your goal is often to buy time, but you have to differentiate between true preterm labor, which requires documentable changes to the cervix, and just preterm cramping.
Right. If it's true preterm labor, we administer telecolytics. These are medications designed to halt contractions.
Drugs like subcutaneous terbutaline or IV magnesium sulfate.
How exactly is mag sulfate stopping a contraction anyway?
Well, magnesium essentially competes with calcium at the cellular level. Contractions require calcium to fire the smooth muscle of the uterus.
Oh, I see.
Yeah, so when you flood the system with magnesium sulfate, it relaxes that smooth muscle, effectively turning off the contractions.
And we use that window of relaxation to administer corticosteroids, like betamethasone, to the mother?
Right. That steroid crosses the placenta and artificially accelerates the maturation of the fetal lungs, prompting them to create surfactant.
That is the ideal cascade. But let's return to my scenario where the water has broken prematurely. PPROM. The protective barrier is gone, which drastically increases the risk of an ascending intraamniotic infection called chorioamnionitis.
And this is where your nursing interventions completely shift. Because the absolute worst thing you can do for a patient with PPROM is a routine digital vaginal exam.
Right, because every time you insert a gloved finger to check the cervix, you are physically pushing naturally occurring vaginal bacteria higher up into the sterile space.
Precisely. You avoid digital exams unless absolutely mandatory, opting for sterile speculum exams if needed, and you monitor hawkishly for the triad of chorioamnionitis,
which is purulent amniotic fluid, a maternal fever over 100.4 degrees Fahrenheit, and fetal tachycardia.
Which actually ties back to our monitor interpretation. If the fetal heart rate baseline shoots up over 160 and the mother is spiking a temp, we assume chorioamnionitis until proven otherwise.
That pattern recognition again, I love it.
There's another clinical trap here involving diagnostics. Providers will often order a fetal fibronectin swab. Students sometimes confuse this with an infection test.
Oh, but it's not, is it?
No. Fetal fibronectin is essentially a biological glue that keeps the amniotic sac attached to the uterine lining. If it's leaking into vaginal secretions early, it's a predictor of imminent preterm labor, not a marker of infection.
That's a crucial distinction. So the governing rules for the premature cascade. Preterm labor is defined by actual cervical change. We use tocolytics like mag sulfate to relax smooth muscle and delay delivery, specifically to buy time for corticosteroids to mature the fetal lungs.
Spot on. And if the water breaks early, the massive risk is chorioamnionitis, meaning routine digital exams are strictly off the table to prevent pushing bacteria upward.
Okay, so we just talked about the body going too fast or initiating the process too early.
Right.
What happens when it completely stalls out? Like when labor is dysfunctional and requires manual intervention? I see the terms induction and augmentation thrown around in clinical settings interchangeably all the time. But from a safety perspective, what is the core difference?
It really comes down to the starting line. Induction is initiating labor entirely from scratch.
Meaning the body wasn't planning on going into labor today.
Exactly. But we are forcing the issue using cervical ripening agents, or oxytocin. Augmentation, on the other hand, is stepping in to assist a labor that already started spontaneously but has stalled out. The contractions exist, but they are ineffective.
And the risk with both, particularly when administering oxytocin, is hyperstimulation of the uterus.
Yep.
We are artificially forcing the muscle to work, which can easily cut off the oxygen supply we talked about earlier. And you definitely cannot induce or augment if the baby physically cannot fit.
Right. If there is absolute cephalopelvic disproportion, meaning the baby's head is simply too big for the maternal pelvis, throwing oxytocin at a blocked passage will only lead to that uterine rupture we discussed.
Which is why we have to talk about malpresentation. The expected, safe presentation is vertex or head down. But if the baby is breech, whether frank, complete, or footling, the dynamics completely change.
A breech presentation dramatically increases the risk of a prolapsed umbilical cord. The irregular shape of the baby's bottom or feet just doesn't plug the pelvic outlet as cleanly as a hard, round head.
So a provider might attempt an external cephalic version, an ECV, where they physically place their hands on the mother's abdomen and try to manually roll the baby into a head-down position.
It is a really high-risk maneuver. The nurse must ensure an emergency C-section team is on standby.
Because forcefully rolling the fetus can cause the placenta to shear off the uterine wall in abruption or cause the umbilical cord to wrap tightly around the baby's neck.
Exactly. And if the baby is head down, but the mother is exhausted after a prolonged second stage of labor, we look at operative vaginal delivery. Forceps, or a vacuum extractor.
And every intervention introduces trauma.
This is a massive testing area. You must understand the specific mechanism of injury associated with each tool. Let's look at the vacuum extractor first. The provider places a suction cup directly on the top of the baby's skull.
Right, so the pulling force is entirely on the scalp.
Because of that suction and pulling, you risk rupturing blood vessels between the skull and the periosteum, creating a cephalhematoma, a contained pool of blood on the top of the head.
Okay, I'm with you.
And as a nurse, your critical thinking has to go one step further. Over the next few days, as that newborn's body breaks down that trapped pool of red blood cells, it releases a massive amount of bilirubin,
which overwhelms the newborn's immature liver, significantly increasing the risk of severe jaundice.
Wow, that is a brilliant physiological connection.
Yeah, vacuum equals top of the head trauma, leading to cephalhematoma, leading to jaundice.
What about forceps? Well, the mechanics are entirely different. Forceps are metal blades that slide into the birth canal and clamp onto the sides of the baby's face.
Oh, I see where this is going. The facial nerve runs right across the cheek.
Exactly. The crushing pressure of the metal blades against the cheekbones can damage that nerve, resulting in a newborn facial nerve palsy. When the baby cries, you'll see a distinct asymmetry in their facial muscles.
So we anchor the complication to the placement of the tool. Vacuum goes on top of the head, causing cephalhematomas. Forceps go on the sides of the face, causing facial nerve palsy.
Perfect.
And backing up to the broader interventions. Induction is starting the engine. Augmentation is hitting the gas. A breech baby leaves terrifying empty space for a cord to prolapse. And attempting to manually flip that baby via ECV carries severe risks of placental abruption or cord entanglement.
If you can trace those mechanisms of injury, you will not be tricked by exam questions that try to mix them up.
Stepping out of the clinical mentor role for just a second. If you're listening to this, you are doing incredible work. I mean, this material isn't just dense, it carries immense emotional and physical weight. The stakes are literally life and death.
They are.
But mastering this physiology, understanding the why behind the textbook rules, is what will make you a phenomenal, safe nurse.
The memorization eventually falls away, and the clinical reasoning takes over. You stop seeing arbitrary rules and start seeing the interconnected plumbing and wiring of the maternal fetal unit.
To leave you with one final clinical reasoning thread to pull on, think about the domino effect of interventions we've discussed today. Everything in OB is connected. Imagine a scenario where a provider performs an early amniotomy. They artificially break the amniotic sac to try and speed up a stalled, dysfunctional labor.
But ask yourself, what if the baby's head isn't fully engaged deep in the pelvis yet? When that protective water violently gushes out, the umbilical cord can wash down right past the unengaged head.
Oh man, now you've created a prolapsed cord.
Exactly. What was supposed to save an hour of labor just created a 3-minute race to the operating room.
Next time you look at a complex obstetric chart or stare down a tricky NCLEX scenario, trace the interventions back to the source. Ask yourself, what domino did this knock over? Best of luck on your exams. Trust the underlying mechanisms, trust the patterns we just went over, and trust your clinical judgment. You've got this.